I'm Dr. Monisha, postgraduate student in Department of Biochemistry, Jawaharlal Institute of Postgraduate Medical Education and Research, Puducherry, India. I'll be talking about today on familial tumor calcinosis, a case which we have seen in our daily rounds. I'll be talking on introduction, clinical case, and the lab workup, how we made it, and finally discussion and summary. Before going on to the clinical case, I would like to give a brief introduction on familial tumoral calcinosis. Tumoral calcinosis is a very rare disorder with mortality with calcification of soft tissues around the large joints. It's not a true neoplasm. It doesn't have any proliferating cells. Etiology can be sporadic or familial or due to secondary causes like CKD or hyperparathyroidism. I'll be explaining on detail on familial type. Familial type can be hyperphosphatemic variant or normophosphatemic variant, mainly due to loss of function mutation in FGF23 gene and GAL-NT3 gene and alpha-klotho. In our case, a 9-year-old boy who is a known case of tumoral calcinosis, he presented to us with progressive painful swelling in his right gluteal region for past 5 years. He was diagnosed at the age of 3 years following an excision biopsy. And he had recurrence of the tumor post-surgery with additional skin lesions in the upper limb and axilla. Family history, there is no similar family history in his sibling. He was born to a third-degree consanguineous parents. On examination, a tender, warm and non-tender warm firm swelling was noted in his right hip, accompanied by dilated veins. X-ray showed calcification. Dual energy X-ray absorptiometry showed osteopenia. On further evaluation on lab workup, we found that serum phosphorus level were high, but other parameters were normal. Surprisingly, it was normal. On further evaluation on calcium phosphate disorder, we found that FGF23 was significantly higher and we evaluated further. This is his urine spot value reports. And we further wanted to check his phosphate clearance in the kidney. So we opted this TMP-GFR formula. First step, we calculated phosphate clearance to creatinine clearance. We found that this is the value of phosphate clearance to creatinine clearance. And then in order to find fractional transport reabsorption of phosphate, we use this formula. His TRP was 0.99%. Normally, tubular phosphate reabsorption will be 78 to 91%. It was more than that. If TRP is less than 0.86, we'll be applying this formula according to the protocol. Since our value was 0.99, we used another formula because if TRP is more than 0.86, it will follow a curvilinear relationship. So this formula was opted. KMP-GFR was calculated. It was 3.73 millimoles per liter. I have represented in milligrams per deciliter also, as well as in millimoles per liter. So this boy was 9-year-old. So according to his reference interval, his TMP-GFR was high, which means there is more of phosphate reabsorption. Moving on to discussion, to summarize the case history, a 9-year-old boy with a known case of tumoral calcinosis with hyperphosphatemia and all other parameters were surprisingly normal with elevated FGF23. We have to know about FGF23. FGF23 is a fibroblast growth factor 23 secreted by osteoblasts and osteocytes in response to high phosphate levels, which will act on kidney via alpha-klotho. FGF23 gets activated when it is acted upon alpha-klotho. When it gets activated, it will suppress 1-alpha hydroxylase, thereby decreasing the absorption of phosphate as well as calcium from the intestine. And it will suppress sodium phosphorus 2A transporter, which is present in the kidney, which will further decrease the reabsorption of phosphate. To conclude, whenever phosphate is high, this FGF23 will increase and it will try to eliminate the phosphate from the body. So it is a phosphaturic hormone. This is a normal mechanism of FGF23. So whenever FGF23 is high, it will try to decrease your phosphate level by decreasing the reabsorption. Whenever FGF23 is low, it will try to increase the reabsorption by increasing the TMP-GFR, and it will increase the serum phosphate level. This is a normal mechanism. In our case, we found that in spite of increased phosphorus level, with other clinical things, other lab findings and clinical things were within the normal range, other than the tumor. On further examination, FGF23 was high, and it was expected. Whenever FGF23 is high, tubular maximum reabsorption should be low. And our instance, what happened was, it was surprisingly high. So this discrepancy could be due to potential genetic mutations leading to resistance in FGF23 activity. That could be due to alpha-klotho mutation. So based on this TMP-GFR results, patient was advised to take low phosphate diet and phosphate binders like sevelamer. On follow-up on the treatment, patient phosphate level came down. Limitations of this TMP-GFR are whenever GFR goes down, it is mainly based on GFR. In CKD patients, it is not that much reliable. And influence of medications like diuretics can affect this TMP-GFR, and variability in measurements and limited sensitivity. This is the summary. A 9-year-old boy with tumor calcinosis with hyperphosphatemia and elevated tubular maximum reabsorption of phosphate despite raised FGF23, which indicated us that there could be secondary resistance to FGF23, which made us to suspect mutation in alpha-klotho. Due to limited resources and financial constraints of the patient, genetic evaluation was not done. With FGF23 and TMP-GFR results, patients was advised to follow low phosphate diet, and he was started on phosphate binder. So this signifies TMP-GFR tool in treatment decisions and in follow-up, particularly in a resource-limited settings in India. These are my references. Thank you.